of PEEP on the respiratory pump.
Okay, thank you very much, Gordon. Yes, so we have discussed quite a lot the effect of PEEP on the lung, or maybe hemodynamics, but I think the effect of PEEP on the respiratory muscles is largely neglected. So I'm happy I can talk about that for like the next 15 minutes or so. So I don't have any conflicts of interest related to the current presentation. So what I would like to do is first discuss the effect of PEEP on diaphragm geometry, the effect of PEEP on diaphragm effort in critically ill patients, and after that, the prolonged effect of PEEP on the diaphragm. So right here you see the diaphragm. That's that fantastic dome-shaped muscle positioned between the thorax and the abdomen. And there's two parts that's really important. The top, the tendinous part, and the lateral part, the zone of apposition, the place where we generate the pressure, the place where the muscle fibers are located. And as you can imagine, upon contraction of the muscle fibers, the top of the dome will move downwards. Also important for this presentation, and I'm sure that you're aware of that, every muscle has a length-tension relationship. So there's an optimal length for contraction. If the muscle is overstretched, you can generate less pressure, and if it's shortened, it will generate less pressure as well. And the biochemical explanation is that you need a certain overlap between contractile proteins, between actin and myosin. So in this study, healthy subjects were ventilated with different levels of PEEP while in a quite sophisticated four-dimensional MRI. And I'm going to show you some of the results right here. So if we increase the level of PEEP, we find a downward movement of the top of the diaphragm dome. In this healthy subject, almost 3 centimeters. So right here, for all the subjects, 5 of PEEP, 10 of PEEP, 15 of PEEP, there is a downward movement of the top, but also the anterior and posterior part of the diaphragm. More or less as expected, I guess. The interesting thing is, if the top of the dome moves downward, the zone of apposition, so the muscular part, becomes shorter, becomes thicker, and also shorter. In fact, it's not this simple at all. It's not like a moving downward cylinder. If you apply PEEP, there's an expansion of the thoracic cage. So what is actually happening, that the diaphragm becomes a widening cylinder. And that has important implications. Just a small sidestep, because you would say, yeah, this is like in healthy subjects, who cares? Well, we did more or less the same in ICU patients, so ventilated patients with ARDS, at this time not in MRI, but with quite sophisticated ultrasound, and we also found that increasing the level of PEEP results in a downward movement of the top of the diaphragm. Okay, so let's go back to the healthy subjects again. So we looked at the contractile properties of the diaphragm. So double balloon catheters, gastric esophageal balloons were inserted, and the phrenic nerves were magnetically stimulated to investigate the pressure generating capacity. And as you can see here, the higher the level of PEEP, the lower the level of pressure that could be generated. So PEEP impairs pressure generating capacity of the diaphragm. In fact, if we looked at the neuromuscular efficiency, so how much pressure do you generate for a certain drive, it decreased with PEEP. Again, a small sidestep, and I think this is important as well. What is the effect of PEEP on perfusion of the diaphragm? So this is an animal study, rats mechanically ventilated at different levels of PEEP, low and high PEEP, and they measured perfusion, blood flow in the diaphragm. And as you can see right here, increasing the level of PEEP actually impaired diaphragm perfusion. And this was at least partly explained by increased vascular resistance. And this is a very nice study because if they open up the abdomen or the thorax, you don't see this phenomenon. So this is really pressure related. So to conclude this first part, what happens if we apply PEEP, at least to the diaphragm, it results in a shortening at the zone of apposition. That results in a reduced contractile efficiency, and also PEEP impairs perfusion of the diaphragm muscle, at least in this animal model. So what happens if we apply PEEP to the effort generated by the patient? This is a fantastic study published in the Blue Journal a couple of years ago. Patients with ARDS at 2 levels of PEEP. So right here, this is the airway pressure, obviously during an assisted mode, airway pressure and esophageal pressure swings. And as you know, the esophageal pressure swings reflect the effort generated by the patient. So if we increase PEEP from 5 to 15 centimeters of water, you'll see right away that swings in esophageal pressure become smaller. So in this representative patient, respiratory effort decreases when you do increase PEEP. And if we look at the data for all patients, right here, 5 of PEEP, 15 of PEEP, esophageal pressure swings, so the lower, the less effort generated by the diaphragm, increasing PEEP, in this case, halved the effort generated by the patient. And the effect was very, very consistent, at least in this study. Honestly speaking, my clinical practice is a little bit less consistent, but at least in these patients, it was very consistent. And increasing PEEP, as expected, reduced tidal volume. It's an important observation, I think. But then the question is, why does PEEP actually reduce respiratory effort? And there's more than one explanation. And looking at respiratory drive, as reflected here, electrical activity of the diaphragm might provide an explanation. But now things become rather confusing. Because in some patients, increasing PEEP decreases respiratory drive. And if respiratory drive is decreased, you can imagine effort decreases. But in some patients, increasing PEEP actually increased respiratory drive, but still effort decreased. So that makes us think. So right here, let us reflect a little bit again on the feedback of respiratory drive. So respiratory drive is generated in the respiratory centers of the brainstem, and there are actually at least 3 feedback pathways. The reason why you're sitting here in this room and you are breathing is because of arterial CO2, or more precise, arterial pH. There's an effect of the cortex. I mean, you can hyperventilate if you become agitated or whatsoever. But right here it's important, there's quite a lot of irritant receptors within the lung. So if there is consolidation, there might be an increase in respiratory drive. So you can imagine if you apply PEEP, the lung becomes more homogeneous, this becomes less important, and respiratory drive decreases, right? So what may happen? You increase PEEP in your So we increase PEEP. In some patients, respiratory drive will decrease, respiratory effort will decrease. So most likely in these patients, lung homogeneity has increased. While in other patients, the increase in PEEP results in increased respiratory drive. Therefore, there must be a decrease in neuromuscular efficiency, resulting in decreased effort. And these are the patients where there's probably a large effect on a zone of apposition. Remember the widening cylinder concept. I'm not sure if this is the explanation, but when I was working on this presentation, I think this is a reasonable explanation for the different effects. Okay, so far we have been talking about the effect of PEEP on the inspiratory effort. So let's talk a little bit about the effect of PEEP during expiration. And this is a very nice study in ventilated children. Right here, this is at PEEP of 5, release of PEEP, again PEEP of 5. I have a little difficulty. All right, it doesn't matter. Below, you'll see the airway pressure, and in the upper signal, you will see electrical activity of the diaphragm. So when PEEP is released, and expiratory diaphragm activity actually increases. And it's very well known. A pediatric intensivist will recognize that the diaphragm develops tonic activity the diaphragm develops a tonic activity when PEEP is released. It looks like the diaphragm tries to recruit the lung. And this is also a very nice experimental study published a couple of years in the Blue Journal. Pigs with ARDS, right here on the y-axis electrical activity of the diaphragm, and on the x-axis time of expiration. So this is a single expiration divided into quartiles. In this pig at 15 of PEEP, and you can see there's a rapid decline in electrical activity of the diaphragm. But now if you're going to decrease PEEP, you'll see that the electrical activity of the diaphragm in the expiratory phase increases. Or what the authors nicely showed, called breaking expiration. The diaphragm breaks expiration. And it's not only the drive, the EDI, but also the transdiaphragmatic pressure. So if you decrease PEEP, most likely the diaphragm is gonna break the expiration. Fantastic observation. So to conclude this part, I think if you increase PEEP, at least in the studies, quite consistently, there's a reduced inspiratory effort. But increasing PEEP has a quite an unpredictable effect on the inspiratory drive, and increasing PEEP reduces the expiratory drive and effort. At least in children and pigs, it seems like adults have a little bit less of this vagal activity, have a little bit less of this tonic activity of the diaphragm. So the final part, 2 minutes, is what is the prolonged effect of PEEP? Again, remember, this is how you are sitting in this room. If I apply PEEP, the zone of apposition is shortened, right? But the interesting thing is what happens when we release PEEP. And that's what we investigated in this experimental study. Rats were ventilated with PEEP, and we measured certain things in diaphragm strips, so strips obtained from the whole diaphragm. And interestingly, what we found already, but in rats things are going quite fast, after 18 hours of mechanical ventilation, the optimal length for force generation of the diaphragm was reduced. So if in the control animals the optimal length of force generation was around 2.2 centimeters, for animals ventilated with PEEP it was around 2 centimeters. So the muscle has become shorter. This is what we have called longitudinal atrophy of the diaphragm. And I'm not going to discuss it into too much detail, but what actually happened, which we analyzed with quite sophisticated techniques, is that the muscle is going to expel sarcomeres. It's going to expel actin and myosin. So the actin and myosin doesn't become shorter, but you're just going to expel a couple of these sarcomeres, contractile units. You could say, who cares? I mean, it's a physiological adaptation, right? Well, remember, this is how we started. So we provide PEEP. The zone of apposition becomes shorter. Muscle adapts. So again, there's an optimal length for force generation. But now as clinicians, we're going to release PEEP during a spontaneous breathing trial. And the adapted muscle is overstretched. And this could be an explanation for a failed spontaneous breathing trial. I mean, this is our hypothesis. I'm not saying that this is going to happen in your patients tomorrow, but I think it's a reasonable hypothesis when the length of the diaphragm is suddenly increased when PEEP is released. Okay, so to conclude, Mr. Chairman, I think I've shown that there are key effects of PEEP on the respiratory pump that we don't consider too much in clinical practice, but that are important. There's a shortening in the zone of apposition, and that affects contractility. There's reduced effort, unpredictable effects on drive. Low PEEP may result in activation of the diaphragm in the expiratory phase, tonic activity to recruit to the lung, and with prolonged PEEP, at least in experimental models, the diaphragm develops longitudinal atrophy, and it's our working hypothesis that this is a mechanism for failing spontaneous breathing trials, at least in some patients. Thank you very much.